Hope you had an opportunity to take a break. Let's talk about hepatic failure part 2. And when we first talked in part 1, we talked about the fact with hepatic failure was divided into two major categories, and that was diminished hepatocyte function, which we've completely covered, and then now we're going to talk about portal hypertension, the things that occur as a result of hepatic failure that causes portal hypertension. And some of this is kind of a repeat of the signs and symptoms that were noted, but we have to identify each issue because it does have separate nursing interventions. So when we talk about the protruding abdomen, we've identified that the diseased liver cells are damaged. And what happens in the liver normally is all blood from the gut, from the stomach, the pancreas, the spleen, all of the intestines, all of that runs through the liver. The liver is the major highway, especially that portal vein. It's the major highway from the GI system, and then once it goes through the portal vein, then it heads back up the inferior vena cava and then goes back to the right side of the heart. And if you think about the highway, if there was some construction on the highway and instead of having this 3 or 4 wide open lanes, now you was down to 1 lane, well then you know that this would cause a whole lot of congestion. And this is what happened when the liver cells are damaged. Scar tissue forms, and then abnormal scar tissue causes compression and obstruction of the liver's normal blood flow. In other words, your 3-lane highway now goes down to one twisty, windy road that leads to the inferior vena cava. And so what happens is venous blood is not able to zoom through the liver, and that causes congestion or backflow, just like it would on the highway if you went down from 3 lanes to 1 lane. And this venous congestion and backflow will cause increased venous pressure in the portal veins, and these veins are not meant to have a high pressure. And anytime, of course, that your pressure becomes elevated, it's hypertension. And because this is in the portal vein, we call it portal hypertension. And this increased vascular congestion or increased pressure causes vascular congestion backward. And where backward? Well, into any of the abdominal organs, because all of the blood from all of these abdominal organs goes zooming through the liver on their way back to the right side of the heart. And what it affects a lot, or at an increased amount, is it affects the stomach, the esophagus, and the spleens the most. These are where we get the most signs and symptoms from. And this increased venous pressure also it increases the hydrostatic pressure, which all that means is that your veins begin to leak, and they leak fluid into the peritoneal space. So if it wasn't bad enough that you have low blood proteins causing fluid to leak into the peritoneal space, well, now you have an increase in the venous pressure, and that causes fluid to leak into the peritoneal space. We had increased blood volume because, hello, we had aldosterone wasn't being broken down. We held on to sodium, we held on to water, and then all that did was just leak into the peritoneal space. And that's why sometimes these individuals just have huge bellies. And so let's talk about the problems that are related to portal hypertension. And of course, we know that hypovolemia, we identified this with hepatocyte dysfunction. Well, it's the same with portal hypertension, and this is why your kidney can truly fail, because all this fluid is just leaving the vascular space. I just identified 3 reasons why water leaks from the vascular space into the peritoneal space, and so this really causes a profound hypovolemia. Respiratory dysfunction because of that protruding abdomen, and then of course the back pressure. The portal hypertension will cause that back pressure or congestion in the venous system, and that causes varices. very important that portal hypertension leads to varices in the esophagus, stomach, and anus. So what do we do for portal hypertension? Well, again, we've got to manage and assess the fluid level, and it is very difficult to maintain that normovolemia. In other words, we want to keep as normal a volume as possible while we've got all these vessels leaking into the abdomen, but then we've got aldosterone floating about, which will cause us to hold on to fluids, so we need to give some fluid, so it's just very, very difficult to ensure a euvolemia, a normal volume status for this patient. Again, assess respiratory function. We've talked about paracentesis. Head of bed needs to be up. We're going to assess renal function. Now, here's a new one, and this individual was on aldactone. We talked about that to reduce the whole sodium water reabsorption thing. This individual is on propranolol or Inderal. This is a beta blocker. Now let's go back to what beta blockers do. They decrease heart rate and they decrease the pumping power, or there are negative inotropes, so that ultimately we get a decrease in the cardiac output and a decrease in the heart rate, and this does help the portal hypertension. So there is no way to measure portal hypertension. We cannot really stick something on that patient and say, well, hey, what's your venous pressure doing? We can just kind of go by some of the signs and symptoms. We'll get to that in just a minute. But again, Inderal, beta blocker, we want to reduce the cardiac output and the heart rate so that we reduce the portal hypertension. Now, another intervention that's used in the treatment of portal hypertension is TIPS, and that's transducular intrahepatic portosystemic shunt. And what this is this is a procedure, so it's usually done in the interventional radiology, to create a new connection between two blood vessels in the liver. And what this does is just reduces the portal hypertension and the complications associated with portal hypertension. So it's kind of like creating an alternate highway so that blood can zoom through the liver and so that portal hypertension is reduced. This individual is, as I said, it's the TIPS procedure is done in the interventional radiology. That is not a surgical procedure, as in we don't slice and dice. This patient will have conscious sedation. And you know, anytime you give conscious sedation, they have to be NPO. We access through the jugular vein. A stent is used to connect the portal vein to another hepatic vein, and that reroutes the blood, which allows that blood to zoom through the liver and will reduce the portal hypertension. Let's talk more about portal hypertension. This lady had dark stools and a cough and a hemoglobin that was decreased, as well as being weak. Well, what happens with portal hypertension is we have vascular congestion backwards that affects the other abdominal organs, and we said a lot of effect on the stomach and the esophagus and the spleen. And what will happen is these things called esophageal varices may form. Now, if you think of a varicose vein on your leg, it's a dilated vein. And what happens is these veins in the esophagus will become engorged or enlarged. And these swollen blood vessels become more fragile because they're swollen and they're not meant to be, and they can easily bleed. If these individuals increase their intrathoracic pressure, in other words, if they bear down while they're having a stool, or if they cough, or any of those other things, well, that can cause these esophageal varices to pop. And you can see down here is a picture of what happens when these esophageal varices pop. Then you get bleedings. And I've had a patient in the intensive care unit where they had esophageal varices bleeding, and these individuals can bleed a lot because, again, they're at risk for bleeding because they can't clot with all of their protein issues, and this individual wound up dying because their esophageal bleeding was so severe. Let's talk about what kind of problem can occur from the esophageal varices. Well, we already talked about that. Any increase in intra-abdominal pressure, cough, sneeze, or bearing down, the Valsalva maneuver can cause these varices to pop. So you want to constantly assess their stool. and assess them for signs and symptoms of anemia, fatigue, shortness of breath, dyspnea, and pallor. And we want to assess them for bleeding, whether it's frank bleeding, such as hematemesis, or just bloody vomit or coffee ground emesis, dark stools, or bloody stools. So anything that can be associated with bleeding from the GI tract. Because again, they can also get these varices in their stomach, and so the blood may go from the stomach downstream and then it'll come out through the rectum, and then that's what you're getting, that dark stool. Again, propranolol is used to reduce the risk of bleeding. So we cannot directly measure portal hypertension. We can only measure blood pressure. Well, you know, blood pressure, when you measure it, you're measuring arterial side. You're not measuring venous side. So it's worthless to measure. I mean, obviously we do measure the blood pressure because of many other reasons, but you cannot tell if the Inderal is directly reducing portal hypertension unless you see no bleeding. If there is no bleeding, then you can say, okay, we haven't had any popping of the esophageal varices, and so the Inderal must be doing the trick. But to measure arterial pressure is not quite going to determine whether the propranolol or Inderal is helping with the hypertension on the venous side of the fence. Let's talk about more with portal hypertension. We have a cough, a decreased platelet count, hematocrit, and hemoglobin. And again, we've talked about the fact that portal hypertension will greatly affect the spleen, the esophagus and the stomach by causing varices to develop. Well, what happens with the spleen? You get, again, this back pressure, and so your spleen becomes enlarged. And what should happen is that your blood also goes through the spleen. It's like the filter, and once all your blood goes through the spleen is kind of like a blender. As soon as the red blood cells, white blood cells, and platelets pop through, the spleen kind of acts like a blender, and it filters and it cleans and it makes sure there's no microbe on these cells, and then it sends it on out to the rest of the GI tract. Well, what happens with this portal hypertension is this back pressure causes all of these red blood cells, white blood cells, and platelets to get trapped. And because the spleen is like a blender, because it's always cleaning and mixing and doing all kinds of things to keep all of our cells healthy, it just gets trapped in this blender, and therefore those cells get destroyed. And once those cells are destroyed, then it's going to reduce the count. It's going to reduce the white blood cell count, the red blood cell count, and the platelets. And when all of these three types of cells, the whites, the reds, and the thrombocytes or platelets are reduced, that's known as pancytopenia. That's just another term for you to remember because you don't have enough to remember. Let's talk about problems from splenomegaly. Well, if you have bleeding problems because your platelet count is dropped, you have infection because your white blood cell count is dropped, and you have anemia because your red blood cell count is dropped. Again, we have problems with anemia because we're at risk for bleeding also, so it's just a mess. These hepatic failure patients are very, very sick. Again, assess for your signs and symptoms of anemia, assess and report signs and symptoms of bleeding, prevent and monitor infection. These individuals need to be very current on all of their immunizations because the last thing they need is to get a pneumonia or the flu. They need to get all these preventative vaccines. And then, of course, Inderal, again, to reduce the effect of portal hypertension, which will reduce the problem of splenomegaly. Let's say that this individual does get bleeding esophageal varices. What is the treatment once these esophageal varices do start to bleed? Well, again, you're going to replace the blood with red blood cells, and usually it's considered that platelets and plasma has to be given kind of on a 1-to-1 ratio. You give 1 unit of blood, well, you need to give some plasma or platelets so that you replace the clotting factors in the blood as well as the red blood cells that carry the oxygen. These individuals will go for an endoscopic examination. They'll go to the GI lab, and sometimes they will absolutely directly administer vasopressin, which we know from our previous course or previous unit, Unit 2, that that is a vasoconstrictor. Now let's talk about vasopressin. It's a great drug because it does produce the vasoconstriction of the blood vessels and will reduce it will reduce the portal blood flow and reduce portal hypertension. That's all good. We want it to do that. That's why we've been shooting this drug into those esophageal varices. But here's the bad thing. It's a vasoconstrictor. And if this individual is unlucky enough to have not only hepatic failure but coronary artery disease, that vasopressin can vasoconstrict the coronary blood flow. And it can drop the heart rate and then increase systemic blood pressure. So, because you're vasoconstricting. So, these are not good side effects for an individual with coronary artery disease and known arterial hypertension. Now, nitroglycerin is sometimes given in adults with heart disease if we are doing vasopressin to reduce the esophageal varice bleed. So this will help with the coronary blood flow and reduce arterial blood pressure. It doesn't do a whole lot for the venous side, and because we're usually injecting the vasopressin directly into the esophageal varices, you have vasoconstriction of those vessels, and then you do nitro for the other side. What about if the bleeding doesn't stop? Well, again, if the varices don't stop, or if they're very, very severe, then they can do what's known as variceal banding. And when you look right here, you can see this varice right here, and it's fairly large, is bleeding. And what can happen is they can take this little, it looks just like a rubber band, but it's a clear band, and they can just basically tighten it around that variceal, the esophageal varice, and basically it will cause it to just stop bleeding. It's basically like a tourniquet over a venous system. So let's say our patient, we'll get back to a patient scenario. She returns from the GI lab after she's had vasopressin to control the esophageal bleeding, and she complains of nausea and vomits. And when she vomits a second time, well, this caused another esophageal varice to burst or rupture, and this time her vomit contains frank red blood. Now, what are the treatment priorities? Well, of course, you're going to remain with the patient because she is vomiting up blood. She has the risk of aspiration, so you want to make sure you have suction available, ensure a patent airway because she's losing a lot of blood. We want to do vital signs, and the physician needs to be notified. If the bleeding is not able to be controlled with the vasopressin and the other treatments that she's done, and she starts to vomit again, some physicians will put what's called a Sangstaken-Blakemore tube in at the bedside. And let me just show you what this looks like. This is a honkin' big, massive thing, and it looks like an NG tube, except, and here's a picture of it right here, except it's much, much bigger. And you'll notice you have 3 ports here, and you have 2 balloons. You have this big balloon which will become inflated from one of the ports and will become inflated, and it again is just like applying a tourniquet to these esophageal varices that are bleeding. Then you have another balloon that will go into the stomach through that sphincter there, and when that balloon is inflated, then it acts as an anchor so that these esophageal balloon will stay put, stay where it's supposed to, and here's a better picture here. So here's your esophageal balloon inflated, and then your gastric balloon that's inflated, that can not only compress gastric varices, but also will anchor the balloon so that this balloon doesn't slide up and forward. And then there's a third port that's known as the gastric aspirating tube, because again, if you have a lot of blood or just gastric secretions that are in the stomach, well, you want to decompress that, and you want to remove that. So that we'll be removing gastric secretions, using the balloon in the stomach to either anchor the tube and or to compress the gastric variceals, and then you have this huge balloon that's in the esophagus that will compress the esophageal varices. Again, gastric aspiration is needed if there's any blood in the stomach. So not only do we want to decompress it because it'll make the patient very nauseated, but we also want to get rid of that blood that's in the stomach, because remember, blood as it flows through the GI system, will be broken down and will produce ammonia. Now, the biggest thing with this tube, yes, it's in the esophagus, but you've got to ensure a patent airway. And if for some reason this gastric balloon becomes deflated or slightly deflates, if this tube shifts upward, well, now you have this esophageal balloon that's inflated that could potentially occlude the airway. So if your patient becomes in presents with respiratory distress, then this balloon here is huge. I'm not exactly sure how much air must be inflated in it, but I would say it's about 50 cc's, and to try and to get that balloon to deflate would take far too much time when your patient's in respiratory distress. So you've got to have scissors at the bedside, because what you would do is just cut all of the balloons and then just quickly remove the tube. And of course you need suction at all times. And then the pressure on the esophageal balloon needs to be reduced every 8 to 12 hours, because you don't want it to be that tight, that big. Yes, we want it to compress the varices, but we also don't want esophageal necrosis. I hope this has been helpful. If you have any questions, be sure to contact me.